Chapter 57 is fairly similar to Chapter 56, and they're very finite in what's typically asked about this. However, you might see it a little bit more in practice because, and we've talked about this frequently, about how a lot of our medications are contraindicated with individuals with glaucoma. So because of the prevalence of glaucoma, you might see more of eye drop treatment related to that. So I wanted to point out a few things here. I wanted to point out this figure here. So this is on page 888. Mydriatic drugs, and again, you might see this in the stem of a question. Think mydriatic drugs dilate the pupil. That's easy because it has a D and a D. So mydriatic drugs dilate the pupil. Miotic drugs constrict the pupil. To me, I do the O. So iotics here constrict the pupil. Don't have to worry about this cycloplegics too much because typically we don't do that at the bedside, but we'll use lots of mydriatics or miotic medications. So first, understand that. Secondly, I want you to look at the types of glaucoma, because when we've mentioned glaucoma throughout the semester, we've just mentioned it overall as glaucoma, not angle closure glaucoma or open angle glaucoma, and I'm really not wanting you to focus on it, just understanding that there is a difference, especially if you look at onset and race that's associated with it, and then they have similar symptoms, and then they have very similar treatment. And really, when you look at what's happening with glaucoma, it's too much fluid in the eye. So when we have that too much fluid, that's going to cause all of those problems of blurred vision and the headache, etc. from it. So if you can understand what it is, too much fluid in the eye, then it makes sense that the type of treatment we're going to do is to get rid of that fluid behind the eye. So that kind of guides where we're going next. So there's a couple of different medications when we look at our anti-glaucoma medications. The first one being cholinergic, our cholinergic medications. Get down to here. Okay, so when we get to our cholinergic medications, think on these that we're having that pupil constriction, so it's going to cause vasodilation of those blood vessels around the eye, which is going to allow the drainage of that aqueous humor, so decrease that sensation of that pressure buildup inside the eye. Usually there are only, the only contraindication for these drugs is the drug allergies, and then the adverse effects are limited to the eyeball. So it's usually blurred vision immediately after they've done the eye drops, so we need to tell them to wait 5 or 10 minutes before they attempt to walk around because we don't want their eyesight to be blurred because of that. Very unlikely with any type of interactions with those medications. One drug of choice here is our Pilocar. Again, to me, it's got the O in it, so it helps me remember the O is otic and constriction. So Pilocar we use for that pupillary constriction to help with that power, or that, liquid buildup. Moving to our next one are our sympathomimetics or my mydriatic drugs. My mydriatic drugs have that D in there, so they're going to work to dilate. Go down that. So they're going to work to dilate the pupil, and when we have that, it's going to reduce that reduce the elevated intraocular pressure. We usually can use this long term. The only contraindications are drug allergy. Again, those adverse effects are limited to the eye, so they can also have some blurred vision. And on this one, they have a little associated burning that happens. When they have that burning, it will go away. So tell them to be calm, be still, don't rub their eyes for about 5 to 10 minutes, and that burning will subside. Again, no significant interaction with these medications. My drug of choice for this one is my propine. So my propine is going to work to decrease that intraocular pressure for my by working as a mydriatic drug. I do have a little bit on beta adrenergic blockers because we seem to see a lot of individuals that'll come into the hospital with something else, but then they'll be on these medications for their glaucoma, but we might be treating them for a gallbladder or something like that. But then they'll bring these from home. So I wanted you to be aware of some of them if you see those in the hospital setting. That bioptic and that timoptic, again, both of them are utilized for those for our patients with glaucoma. So be able to recognize those terms. If you do have an individual that's on multiple medications, eye drops for glaucoma, we typically want to give one of the medications, let their eye rest for about 10 minutes, and then come back and give the second medication. That's one thing. Another HESI-NCLEX question is, if they keep them in the refrigerator, we want to have that warm, so they need to set it out for about 30 minutes prior to giving so that it won't be extremely cold when we give it to the individual. There's a little bit in your book about osmotic diuretics for the eye, and again, we just don't see that as much, so I'm not going to spend time stressing you out about that. I do want to pull this over and encourage you to go to the end of the chapter. So again, look at the end of the chapter where we're assessing, doing our nursing process. Assessing is going to be obviously assessing their eyesight and knowing what's normal for them, because as it progresses and gets worse, then they'll have to either go up on their dosage of their eye drops or switch eye drops altogether to a different time. So I really wanted to focus on the implementation, because this is the question. This is where they get their questions on boards for this one. So when we use this, we don't share eye drop containers. One eye drop container per individual. When you're applying eyes, first you want to clean the eyes first, especially if there's any crusty material in the eye. So making sure you're wiping from inner canthus to outer canthus. Think of nursing 320, how we're doing that in health assessment. Applying pressure to that inner canthus, so the inside of the eye, right where it meets your nose, for about 1 minute. And then when we're that will keep that medication from going systemic with that individual. We want to make sure that we're applying it in the conjunctival sac. So put it in that conjunctival sac, never directly on the eye. Have them look up, tilt their head back, put it in the conjunctival sac, and don't touch the dropper to the patient's eyeballs. That's the NCLEX question, which is kind of humorous to me. And then make sure that if we are doing more than one eye drop, to space them out with about 5 minutes between, 5 to 10 minutes between eye drops on that one. So there's a lot of information on this chapter, really boiling it down to what you need to know. The things we just went over here in the implementation will go towards any of our eye drop medications. So whether it's something for glaucoma, or if it's something for, say somebody's got pink eye, so for antimicrobial, it would still be the same premises. So put it in the conjunctival sac, have them look up, put pressure on the inner canthus so it doesn't go systemically, and don't touch the eyedropper to that individual. I have not had any of these questions asked, and these on diagnostic medications typically go a little bit more if you're working in an optometrist setting, or what we're seeing a lot of now are our standalone surgery suites that are doing LASIK or removing cataracts, that type of thing. So if you're in that, then you would use these more frequently. But for overall purposes for eye drops, focus on this implementation. We don't have anything in chapter 58 on our test, and I haven't heard it on HESI, but it might be on NCLEX. This is the one chapter the one sentence in the entire chapter I would tell you to know. Because you will give eardrops at the bedside, not all the time, but sometimes. So if I'm giving eardrops to an adult, hold the pinna, which is this part, hold the pinna of the ear up and back, and then if it's a child under 3 years of age, you're going to hold the pinna down. So you're going to pull this part of the ear down. What you're trying to do when you are pulling the ear is, let me get to the picture, is when I'm trying to straighten out this ear canal. So if you think about an adult, we have to hold ours up, because look how this adult is kind of drifting down. So if I hold it up, that's going to straighten the canal. Whereas I'm going to hold a child's down so that theirs typically goes up like that, so that it gets in the eardrum. So that's the only sentence, let me go back to it, that I need you to know in this whole chapter. Again, you won't have it on my test, you won't have it on HESI, but you might have it on NCLEX. So hold the pinna up and back for adults. Under kiddos, you want to hold that down and back. If you have any questions on either chapter 57 or 58, don't hesitate to holler at me.